This is LiveWell Talk on pain management and treatment. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health St. Luke's Hospital. Joining me today on the podcast to discuss chronic pain and its treatment is Dr. Kathryn Reed, a pain medicine specialist and board-certified anesthesiologist with Linn County Anesthesia. Dr. Reed, welcome.
Thank you for having me.
Well, the CDC says that about a fifth of the population deals with some sort of chronic pain. We're in the middle of an opioid epidemic that's been going on for a while, the issues of fentanyl, et cetera. Maybe we ought to just start out, what is chronic pain?
Right, that's a good question. Chronic pain typically can be defined as pain that lasts longer than a typical acute process is expected to last. So some people could have a sprain or a strain that we expect to heal, or have even a surgical intervention and you have an expected time frame of healing and their pain persists past that expected typical time frame. It can vary anywhere between 3 to 6 months, typically before we decide to define it as chronic pain. And that would be based on the patient's presentation or what we think maybe caused the pain to begin with, to start with.
In your practice or in your experience, what do you think causes people to have chronic pain? Because some people have the same surgery, recover fine. Other people, no. So what, in your opinion, what do you think predisposes people to
Right.
that?
I think that there's so many factors when you're considering chronic pain and how patients respond to healing. You know, people can have degeneration of their bodies, whether it's arthritis or age-related changes, structural changes to their body that has occurred maybe due to a fracture that has altered their anatomy, muscle tone, overall muscle strength that can lead somebody to having chronic pain. So that it's really not a very specific, like this leads to this. It is really a combination of factors that contribute to somebody not healing in an expected time frame or responding to an insult to their body in a way that just never really heals appropriately.
I professionally correct patients when I'm encountered with a conversation. I know you've heard this too. I have a low pain tolerance, or she has a high pain tolerance. I'm like, pain, you can't compare patient A to patient B because it's just different.
And there, yes.
So when the family says, well, grandma has a high pain tolerance or low pain tolerance, it's what grandma feels.
Right, it's very personable.
I'm not here
personal.
to rate what your pain tolerance is, nor, it's like I always say, the sight of blood bothers me, specifically when it's my own.
Right.
Right?
Very true.
I mean, that doesn't mean I'm a weak person. I just don't like to bleed.
Yeah.
And so, but how do you individualize your treatment plans then? Because of the wide spectrum of these patients.
So, you want to get a good history. You want to understand their background, what traumas maybe they've experienced, what the evolution of their what their pain history has been, and what things that they've done, how they have kind of gone through this pattern where they are in your clinic. A good physical exam to see, how they hold their bodies, what their posture is like, where their strengths are. Do they have core weakness that's contributing to the back pain? And then in conjunction with looking at their imaging, X-rays or MRIs and things like this, and globally just take into account all of these factors when you're trying to diagnose somebody with a condition to see what is an appropriate intervention and, what you can offer that patient to help.
I remember a couple winters ago, it's prior to the pandemic, but snow was really heavy. I couldn't move with my snowblower. Long story short, shoveled. Kind of developed some tendonitis in my wrist, and it lasted like maybe 7 days or so. It really bothered me, but I thought to myself, man, this has just put me in a bad mood, right? Because every time I go to use it, it hurts, and I thought, wow, this is much what patients that have chronic pain have to deal with every day.
Yeah, it can be very debilitating, very limiting to their desire to want to engage in activities, to engage in social functions. If your back hurts, maybe you can't even go watch your grandkid perform in the recital because it's too hard to walk that length from the parking lot into the facility or to sit for a prolonged period of time.
Yeah.
And then you start decreasing that engagement. And as we know from the pandemic, when people do that, your mental health can decline. And so overall quality of life, functionality really starts to decrease because you may change the way that you behave because of this symptom, because of what you're feeling.
Now, what is the most common that you see up in the pain clinic? Back pain?
A lot of back pain. I mean, we see, I would say a lot of patients have back pain, chronic neck pain, axial neck pain, axial back pain. Those are some of the chronic, very common chronic pains. Some people do have pain that will shoot into their arms or into their legs, and that is a different kind of subset of pain. Some people have pain of a shoulder joint or of a knee joint, pain in the buttocks or into the hip joints. Those kind of are more common, presentations that we see, complaints that we have of patients that come in, and then we just kind of start trying to figure out which of the, maybe they have multiple things, which one bothers you the most, because we may have to address different ones at different times and see how we can get their baseline to be, if their baseline is a 7, if we can decrease your baseline to a 5 or a 4, are you more functional? What are you able to accomplish during the day? What activities can you get to? What are you able to do, easier? So.
I think that's been a big paradigm shift for the better. We went through the whole pain as the 5th vital sign. Your colleague, Dr. Klein, can give that lecture about how that influenced opioid prescribing. And he can tell you how he's sitting in a lecture hall where they said, these aren't addictive. If you ever get a chance to talk to Mark about it, it's really interesting. But I do like how we've got away from this number to functional pain. Okay, what is it you want to do? I want to walk better. Okay, let's fix that. Rather than, take you from a 6 to a 3 or whatever.
Yeah, and I think that has to be taken in context. I mean, we do still use these numbers, but it varies for each person.
Right, yeah.
But if you're more functional at a 3, that's what I'm worried about. How can you be more functional? And that number is helpful for that person, but doesn't really transfer over to another person. It's just whatever your patient's numbers are for them.
Right.
And then you use
someone else is 11
totally
and somebody else is 2.
So
That's
just
so true.
Increasing functionality, continuing to have good quality of life. These are the things that we really try to have as, as goals. Like when we're talking about having good goals, what are we projecting here to see, what are we going to have?
So patient comes to the pain clinic and it's interventional pain clinic. I mean, you have these tools that you use. What are some of the tools you use to help people?
Right. We typically use X-ray or the fluoroscopy. That helps us see the bones, see the joints, so that we can target medications like local anesthetics or steroid medications directly in those joint spaces or where we predict the nerves are going to flow over the joints. Okay. Also, we can use ultrasound, which, depending on what the situation is, that can be helpful for peripheral nerves, but frequently we are using X-rays.
And what sort of response do most patients get? Just in my personal practice or taking care of patients over the years, you have some people that go see you guys once and they're fixed, and other people the last couple weeks. And I know you work closely with the spine surgeons and orthopedic surgeons to give some options prior to surgery. Tell us a little bit about the responses that you see.
So it's variable. Some people have really excellent response. It could, a steroid typically takes about 2 weeks to work. So I say don't make any judgments until we're at least 2 weeks into this. For example, if a disc is protruding in their back and pushing on a nerve, our goal is to apply the steroid and specifically to that area to try to decrease the inflammation of the tissues and the nerve to relieve some of this pain that they're feeling. Sometimes that is very helpful and does not require a further surgical assessment. But it's a good first line. If you have pain that's shooting down your leg, having a lumbar epidural would be a good first line of therapies, as far as interventional procedures considered, prior to considering surgery, because you may not need to go and have something as extreme. But each patient's very different. Maybe they don't respond well, and you do need to continue down the pathway, speaking with the surgeon. Patients that have arthritis of the knee, of the shoulder, sometimes we are able to intervene with putting steroids around in the shoulder joint, in the knee joint, and preventing patients from having to, proceed with surgical interventions. One of the procedures that I do is genicular nerve blocks and genicular nerve ablations. The genicular nerve is a nerve that controls sensation of the knee joint. There are 3 nerves that are targeted that control sense of the knee. And if patients have chronic knee pain or really severe osteoarthritis, or the patient is not a candidate to have a total joint replacement or doesn't choose to have a total joint replacement at the time, we can do a 2-step procedure where we go in, block the nerve, the genicular nerve, with local anesthetic, see if their pain improves. And if that pain does improve, we can go in with something called radiofrequency ablation, where we go in and use special needles to heat that area up, and it destroys the nerve at that area temporarily. The nerve will regenerate over time, but it can give substantial pain relief. I mean, a lot of the patients that I've been treating with this have 80% plus improvement in pain, able to go up and down stairs, able to, walk distances that they were not able to walk before. And either they're able to avoid having surgery, or some people have had surgery and it just wasn't, it didn't really increase their quality of life enough. And that's one of the variables that, it's difficult to predict, right? But this procedure has been very helpful.
Occasionally, sadly, you do get a patient that has a total knee joint, and they don't really get the benefit.
Correct. Despite the fact that the procedure is done 100% perfect, it looks great on imaging.
They did their therapy.
They did their therapy. They have good range of motion. There's really nothing from a surgical standpoint to further improve upon. It looks good structurally. And why does that person continue to have pain? I mean, it can be a little perplexing and frustrating for the surgeon, for the patient.
Oh, yeah.
And so then that's when they send them to me, and we are able to try with this procedure.
You did your anesthesia training where?
At the University of Iowa.
At the University of Iowa. And where did you do your pain?
At the University of Iowa.
You went back and did it there?
Yes.
Okay. I knew you did that.
Yeah.
No. Well, if a patient wants to come to the pain clinic, how do they need a referral? How's that work?
Yes, our clinic does work on referral basis. So you would talk with your primary care physician, and make sure that you've had the appropriate workup, which can include physical therapy and getting images prior to coming to our clinic. Or if you are seeing a surgeon, the surgeons will refer too. But we want to make sure that there isn't anything structurally that needs to be fixed, or any other inflammatory condition that could be contributing to this, autoimmune condition that could be contributing to this. So we want to make sure that from a primary care standpoint, the other things have been eliminated, and then they're coming to us, ready for an interventional procedure.
Yeah, I was watching 600-Pound Life the other night. And the lady lost a bunch of weight, and she got neuralgia paresthetica on her thighs, and the doctor now is like, "Oh, I don't know if there's anything we can do." I'm like,
yes,
"Are you kidding me? Just send them to the pain clinic.
Yes, there is.
They'll do a block. She'll be fine."
Yeah, that nerve is such a tiny nerve, and it can have such a profound
This
pain
lady had it
response.
really bad, but I've seen patients that when they have that weight loss, it pulls on that nerve.
Yeah, for sure.
Yeah. Why pain medicine? You are an anesthesiologist.
Yes.
You went back and did pain. What attracts you to that?
Well, that is a good question. I'd always kind of thought about it, even in residency, and my life was just not at a point where I was ready to commit to that extra year of training. I was just starting my family and having a lot of babies, and there's
five babies.
There is a significant amount of radiation that you are exposed to as the pain physician. So I was thinking, oh man, do I really want to do that right now? The answer was no. So I joined LCA, which is fabulous, and we predicted a need that we would. Some of our anesthesiologists that are in the pain clinic are going to be retiring in the next few years, and so they said, if anybody's interested, this would be a good time to go if anyone wants to do further training. And I thought, now's the time. And so I went back and did a fellowship at the University of Iowa for a year, and now I'm here, treating the patients in our community, and it's very fulfilling, to have a patient that you're working through problems with, figuring out how to help them have better quality of life.
Yeah,
I mean,
absolutely.
It's huge.
No,
It's can be very life-changing,
working when I used to work in the wound clinic.
For sure.
At least you see people get better. Usually when you're an internist, you control their diabetes, but it's still there. You control their blood pressure, but it's still there, high blood pressure. Well, Dr. Reed, thank you for joining me, your first podcast, and hopefully not your last.
For sure.
Once again, this is Dr. Kathryn Reed, a board-certified and fellowship-trained pain medicine specialist with Linn County Anesthesia. To learn more about St. Luke's Interventional Pain Clinic, call 319-369-8204. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.